Can you hear me, Clarice? Oh,
Good morning. Good morning.
good morning.
How are
Oh,
you?
all right.
Can you
I'm
hear me?
hearing
I'm
some
hearing an
feedback.
echo. I got technical difficulties. Do you hear the echo? It's like a delay. Okay, let's see. What did I do? Let's see. Let's see. Everything was here fine. What? Good morning, everybody. Welcome. No, it's like a 5-second delay. That is horrible. Hold on.
I can hear it too.
Can you hear me?
I can hear you. Yeah.
Is there still a? I'm trying to see if there's still a delay.
It is.
Yes. Why? Uh, I wonder where is the delay coming from? This is not nice. Hmm. Every time I set this up, I get happy. I get excited. I'm like, we here, we're doing it, and then we're not. Wait, let me see. Let's see.
It just seems like something should be muted somewhere.
I don't know. I have everything that I had before. Can you hear me now?
I can hear you. It's just I can hear an echo. But what I noticed now was like now I don't hear that. I used to hear a lot of like static when I was talking. I don't hear that anymore.
Right. I was hearing that too, and now I don't. And then, um, because you're muted here and on. Wait, maybe it's me. But if I mute myself, you can't hear me
No.
on Clubhouse. If I mute myself,
Right. When you just muted yourself, I couldn't hear you. But it seems to be cleared up now.
I still hear a slight delay, and maybe it's just I need to
But it
turn.
might be just you because I don't hear it.
Oh, okay, cool. Well, if that works, then works. Okay. Well, maybe we good. We gonna try. Welcome, everybody. Welcome. Okay, because we got a lot of stuff to talk about today. We got a whole
Yes.
hot topic, and you didn't have me up all morning doing some research on this whole hot topic. Okay, all right. Well, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, and today some hot topics. Some hot topics. The hottest of the hot topics. How about that? Oh, I'm Clarice Warner. I'm the girl with the pearls, the founder and education director of the Professional Reimbursement Network. Okay, I hear some echo. LLC, where coding education is key. And before I introduce my co host, today's episode is sponsored by the Professional Reimbursement Network's free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
And
It's playing. Well, we'll fix it on the back end. Okay. we'll keep on moving because we can fix everything in the editing process. If I've learned anything, I've learned, girl, just edit it out. Okay. Let me do that. All right. All right. Well, if you are joining us in Clubhouse, welcome. I see Doctor and I see Sandra. Welcome. Welcome to the club. The information, and you're interested in more information on the 5 steps to become a certified marketable medical coder, you can click the link above. If you're joining us via YouTube and Facebook, then check out the video description box for the link. So today, joining me is my trusty sidekick, my co-host, the registered trademark, the coding nurse, Mr. Jesse. So, sir, please introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been an LPN for 29 years. About 2 years ago, I started to create my own business. And what I do now is I help other nurses transition away from the bedside by learning medical coding and transitioning into the wonderful world of health information management.
All right. All right. Well, look at you doing all the things. All of
Trying.
the things. You're succeeding. You're doing them. Just say yes. I'm doing them.
Yes, I'm doing it.
So how's it going? How was your week this week?
Well, I couldn't wait. I couldn't wait because I know we're going to get into our hot topic, but this was good. Earlier in the week, I got an email from AHIMA. Apparently, they were doing an in-depth survey of all their CDIP credential holders.
Really?
And they gave you 1 CEU to complete this pretty extensive survey. And it asked about a whole plethora of things, like what you would do or what you did versus what was expected of the role of CDIP. Then it got to the point where it asked, has the CDIP credential helped you, and would you recommend it to someone? Okay. Well, I let it rip.
Oh, Jesus. Well, that's good that they wanted the feedback, and prayerfully it'll help them in the future with that program and preparing folks for that certification exam. So hopefully you letting it rip did some good for some folks.
I mean, if people would just be honest, then I think it would make a difference. But if you're suffering in silence, it doesn't do anybody any good.
You know what? That is the whole truth and nothing but. Folks just need to keep it 100 at all times. And it's not meant to. Usually the feedback, because I'm one. Tell me if I'm doing something wrong, please. Like, folks will come in my comments and be like, "We can't hear you. This is messed up. I can't do it. Look, let me know so I can learn and figure out, because I'm gonna figure it out."
Right.
But it's not something that I take personally. It's not something. It's a learning opportunity for me. Now, of course, there are certain things that you probably take with a grain of salt, like that don't even apply to me because I don't do that. So, or whatever.
Right.
But things that really are helpful. Oh, I'm all about it. Let me know. I have surveys out the wazoo. Let me know how this is working for you. Let me know how. Bless you. Let me know how I'm helping you, or what have you. Okay, why am I not in the room? I don't see them.
You are.
Oh, it didn't. Okay, it didn't. The whole screen. See, look at. The devil is a lie. Let's just start there.
That's right.
This morning, the devil is a lie. Okay. So one other thing that I want to talk about before we get to the hot topic. Have you seen all the chatter or information about nursing facilities closing like left and right? I've this past week I've seen so many articles about the demise of skilled nursing facilities or long-term care facilities due to staffing, primarily staffing, and I guess financial reasons with ultimately it's the staffing. And so I know a lady that works at a skilled nursing facility, and she had this like huge post, just pleading with people, please go see your loved ones, because oftentimes there are people who have just been placed in facilities and no one goes to see them, and so, and unfortunately, they may not get the most attention, I'll say, that others who have folks there on a regular basis, checking, looking, writing, talking, whatever. And she was just pleading with people, please go see your loved ones, please go see your loved ones. And I'm like, well, what is this all about? And me doing some extra digging, I'm like, oh, they talking about shutting all kinds of facilities down. And I just thought that was so sad, just so sad.
Well, that is tied to this whole um uh I don't know what phrase they're going to give it. They'll give it some kind of phrase, like some kind of nursing outrage. But the staffing ratios in skilled nursing facilities and long-term care facilities are it's been horrible for years.
Mm-hmm.
And now with there being a whole lot with a lot of these nurses being put on trial and being you know put on front street in the media, a lot of nurses are like they're refusing to take on these unsafe assignments. And I just know, like me personally, like when I used to work in long-term care, I worked at facilities where I was the only nurse at night and I was responsible for 60 people. That's a lot of people.
That's a lot of people.
It is.
Because, and I worked in a long term care facility years ago, like at the beginning of my career. And as I was assisting with the coding of the records, and then um, slash, because it's a lot of slashes going on in these facilities in certain in certain um, jobs, slash sitting at the front desk and greeting, really just doing whatever. Like if they call, could you sit here and watch her real quick while I go do so and so and so? So I'll sit there and watch her real quick while they do whatever. Or can you
Right.
help us do, turn it? I'll go help, so slash whatever it was they needed at the time. And yes, it's a lot. And then if you have multiple things happening with several residents at the same time, oh my, and I mean, were you working in at night, like
Yeah,
Thursday?
11 to 7, 11 p.m. to
Okay,
7
but
a.m.
still, you could still there's the possibility, because you have some people who that's their prime time. They up, they chilling, they want to be out and about, and you got to watch them because they'll run or attempt to run. So
And that right there was the problem,
yes,
because you have these people who are active, and then I heard that some of the 3 to 11 nurses would be mad because I wouldn't be there. I would come, and I would never see when they saw me, they never said anything to me. It was stuff I heard afterwards.
okay,
So there were some people, if you're trying to get up out of the bed at 3 o'clock in the morning, I'm not going to let you fall.
right.
If you want to get up, I'm going to get you behind up, put you in a jerry chair, recline you, bring you to the nurse's station so we can look at you. Some people just want attention. And it was this one particular man. I mean, when we would bring him to the nurse's station and put him in a chair and recline him, give him some cookies and turn the TV on, he'd be so happy. I mean, you walk by, he'd be winking at you because he just wanted the attention.
Attention. You're right. He wanted to see and be seen. See and
Exactly.
be
So
seen.
I would rather do that and know that he's not going to fall, because I don't want to stay a minute past 7:30 writing up the incident reports, calling doctors, calling families, doing none of that.
Right. Right.
And it's just me.
Right. Okay. So that was the one little thing. I've just felt in my feelings, like
Well,
probably because I'm
but it's
I'm doing this primary caregiving over here in my house, but I was just in my feelings, like, oh my God, no.
but also the reimbursement has been whittled down to next to nothing. Like the reimbursement has been slashed and slashed and slashed over time, and it's just ridiculous. But it's because people don't really know because it's not really on their radar. Like some people really can put their parents somewhere and not care. There are people who can do that. And if you, to me, I don't think that asking a country to put up money to take care of people properly, because they, back in the day when I first got into long term care, was plenty of staffing. I mean, we used to even have incentives to work on the weekend. You get a bonus. You would get all kinds of things because the money was there. But over time, over like 29 years, everybody talks about the reimbursement. And that's why a lot of people don't like to take Medicare. That's why they don't like to take Medicaid. And our system is for profit.
Yep.
And until it changes, you have to have a decent amount of money in the system for people to receive the services that they need.
Right.
Period.
Right. All right. Well, let's hit our little hot topic today. Let me see.
Yes.
I'm trying something new. So, Lord, here we go.
Okay.
Let's see. Add this to the stream. Yay, it worked. Okay, yay. Okay. Look, I'm trying to be fancy. You fancy, huh?
Uh-huh.
So today we are talking about our coding guidelines, and this comes from the ICD-10-CM official guidelines for coding and reporting. And there have been, Mr. Jesse hit me to this buzz that's all over LinkedIn, I believe, is where you originally saw the information about this particular guideline. And so this guideline is section 1A19, and it's about code assignment and clinical criteria. And it states, the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. And before we go and get deep in battle, and if you're in Clubhouse and want to come to the stage, let us know. We'll definitely bring you to the stage so you can weigh in. And if you are watching via Facebook and or YouTube, please place any comments in the chat, and we'll definitely include you in the conversation as well. So I believe this guideline was added in fiscal year 2017, I believe. And it brought with it a lot of questions and information and well, what and why and all of the things. So I did a little digging, and right after the guideline was published, there was a coding clinic reference that talks specifically to this guideline. And if you want to do some digging and you want to see the actual document, it's in the fourth quarter ICD-10 2016 coding clinic, pages 147 through 149. And so somebody asked the question, please explain the intent of the new ICD-10-CM guideline regarding code assignment and clinical criteria that reads as follows. And you can see that on the screen. We've already read it. It says some people are interpreting this to mean that clinical documentation improvement specialists should no longer question diagnostic statements that don't meet clinical criteria. Is this true? And Coding Clinic gave a huge answer. They said, they said, coding must be based on provider documentation. I think that one statement right there, we all should agree. This guideline is not a new concept, although it has not been explicitly included in the official coding guidelines until now. Coding Clinic and the official coding guidelines have always stated that code assignment should be based on provider documentation. As has been repeatedly stated in coding clinic over the years, diagnosing a patient's condition is solely the responsibility of the provider. Only the physician or other qualified healthcare practitioner legally accountable for establishing the patient's diagnosis can, quote, diagnose, end quote, the patient. As also stated in Coding Clinic in the past, clinical information published, I'm being nosy and then I lost my spot. Clinical information published in Coding Clinic does not constitute clinical criteria for establishing a diagnosis, substitute for the provider's clinical judgment, or eliminate the need for provider documentation regarding the clinical significance of a patient's medical condition. I said, oh. So then it goes on to say that the guideline noted addresses coding, not clinical validation. It is appropriate for facilities to ensure that documentation is complete, accurate, and appropriately reflects the patient's clinical conditions. Although ultimately related to the accuracy of the coding, clinical validation is a separate function from the coding process and clinical skill. The distinction is described in the Centers for Medicare and Medicaid definition of a clinical validation from the Recovery Audit Contractor's Scope of Work document, which is also cited in AHIMA's practice brief, Clinical Validation, the Next Level of CDI, which was published in August, I guess August of the same year, issue of the Journal of AHIMA. And it says, quote, clinical validation is an additional process that may be performed along with DRG validation. Clinical validation involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented in the medical record. Clinical validation is performed usually by a clinician, an RN, a CMD, or therapist. Clinical validation is beyond the scope of DRG or coding validation and the skills of a certified coder. This type of review can only be performed by a clinician or may be performed by a clinician with approved coding credentials. And that's what they said way back when, answering that question regarding this guideline when it first came out. So, Mr. Jesse, I know you have been the man on the streets in these internet streets and all over the LinkedIn post and some of the comments. So I'll let you jump right on in with what you've seen and what's the buzz.
So basically, I have to honestly say your deeper dive cleared up way more than anybody on LinkedIn. Seriously, because nobody in LinkedIn mentioned Coding Clinic. Nobody in LinkedIn even mentioned when this new guideline was even implemented. So basically, Coding Clinic spelled it out very clearly.
I thought so. When I saw it, I was like, that's why I reached back to you and asked you, like, is this the one?
Right. It's very clear that code assignment is different from clinical validation because we know now that's the new buzzword, clinical validation. And we've talked about it in previous weeks how there is an increase in clinical validation denials, but that is a whole separate process and separate from code assignment because of course we all know that all diagnoses are supposed to have meat in order to be coded. We know that.
Correct.
So that will be picked up anyway. We know that a doctor just cannot put gout and then there's been no mention of gout, no kind of treatment, nothing, not even check uric acid level, So I don't understand what all the buzz is because they were talking about how it can facilitate false claims, and I'm like, that's really a stretch.
When I saw all of that, I was like, well, what's happening? What are they talking? What's going on?
I mean, they acted like if you do it this way, you're going to be in trouble, and the provider's going to have you documenting things that aren't really that aren't appropriate. And I'm like, first of all, I had never really heard this much buzz about a guideline anyway. And I'm like, where is all that coming from now? And I think it's because of the clinical validation. And I think that it's because, and also the Coding Clinic made it very clear that clinical validation is above the scope of coding. And that's why coders don't do clinical validation.
And they shouldn't. I mean, if it again, if it's something that you're interested in, there's a path for that. That's a career path or a separate piece or a component that you can add to the skills that you have. Reason for the whole CDI world and what's happening there, as well as auditing and what's happening there. So I was like, well, what in the world? Like, at the end of the day, everybody knows or should know in our world that it's about the provider's documentation. That provider is responsible. That provider attests that the information, not only in the record, but the information being submitted for reimbursement is correct. That it's that person's responsibility. So if you, coder, have a question about anything, that's where the whole query stuff comes in. You need to have conversations. And one of the things that I did a video this week just about which that's a whole other conversation. But I did a video this week about some new guidance that was in the guidelines that came about, that it had been updated in April. And we've talked about that before, how they were adding new codes and new whatever, and the possibility of guidelines being updated in April. Well, they did. And there weren't just chapter specific stuff. There was some basic coding guidelines that were actually updated in April. I hadn't heard anybody talk about that at all. Like, well, this is stuff for everybody. So why y'all not talking about this and telling them? So I did a video on that, which I'll be uploading probably today. So, like, wow, these are the things that, I mean,
Right, that's important.
That's important. That's critical. That you need to know. And even if you're a student, you could potentially be tested on. And if you're working in the field, you definitely need to have the knowledge of. So I'm like, what? I think folks got their priorities just a little skewed, just a little bit, maybe.
They do.
Maybe it's me. I don't know. But one of the things that they mentioned in the guidelines that I wanted to bring to your attention, which I thought it's in the introduction of the official guidelines, and to me this kind of was the icing on the cake. There should be a joint effort between the healthcare provider and the coder, and this is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. The guidelines have been developed to assist both the healthcare provider and the coder in identifying those diagnoses that are to be reported. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Again, without such documentation, accurate coding cannot be achieved. So again, it's about having some conversations, having the conversation about what is happening and what is going on. Yeah, so I was like, well, wait a minute. So then in my digging, I took a look at that AHIMA article about taking coding to the next level through clinical validation, and I said, oh, okay, well let's see what they talking, Harpo, what they talking. and really they're saying pretty much the same thing. They look at it kind of from two veins. One, because I think this is kind of when the start of the RAC audits and the various audits started to ramp up. And so folks were trying to be prepared as much as they could, at least initially. I mean, there's lots of information about things now. I think they do a wonderful job in preparing you and letting you know what their scope of work is, what they're looking at. Make sure. I think they've that program is just, to me, I think they've done a lot of work. And so if you're not plugged in and you get caught out there, it's because you're not doing your homework. You're not investigating. You're not figuring out. I mean, they provide conversations. They have pre-audit discussions and review. I mean, they'll sit down and be like, let me tell you what we're gonna look for. Let me tell you what we're gonna do. And it's up to you to make sure you're in the know about that. But this one comes, I think, from that perspective and understanding what's happening there, but then also for the professional thinking about advancing their career. And so this is an opportunity and what's necessary and what's needed, advancing that career. And then talking about clinical education. So there's a whole little spiel in here about some best practices in developing coding education, specifically clinical education. And the one that I love, and I do kind of miss, and I probably need to just reach out to some doctors and talk to them and be like, can I just come over and visit? It's where, you have those conversations with the physicians. And I take that back. I do get it when I go to that coordination and maintenance meetings with CMS, because then you have the doctors talking about, but this is just for new codes. But anyway, where you have your providers tell you and walk you through and, let you know what their thought processes are. And so just having everybody at the table, which is why I think it's so important to have a diverse CDI program where you have all the different players at the table, where you all can walk through and be like, well, from a clinic or a coding perspective, the rules, the guidelines state thus and thus and thus. The provider can say, well, my mindset and my training, this is where I'm trying to go. And you can have, even your nurses, because y'all at the table as well, where they can come in and provide some additional clinical from their perspective. So I think it's really key just to have everybody sit there. But having the provider in the room and talking about, their perspective, what their thought process is, I to me, that's key. And I mean, I know there's a whole big thing, they're being burnt out from queries and they're tired of you all talking to them about queries. And again, if you would listen or get the education up front, normally, somebody is identifying trends, they're identifying different things when they see denials. And so they're like, okay, let's make sure we provide the information and education to the provider. If you would plug in providers and get that information, maybe the less queries you'll have because you would have absorbed the knowledge and applied it appropriately. Your thoughts, sir? I feel like I've been taking over.
But what you said about the collaboration, in theory it's beautiful, but
Theory.
in day to day that never happens. And the problem with all of this is you have people is, for number one, there is no collaboration.
So why are they
And
not collaborating?
I'm going to tell you,
Okay.
because you have to have, because what happens is the providers complain about the query process. Then what happens is you have managers, because it happened at my last job. You have managers who, instead of using this kind of education, using these kind of facts to educate them, to tell them, listen, this is going to create a problem on the back end if we don't address it now. And use that as a point of opportunity to create educational material to help them increase their knowledge. But instead, I had a supervisor who would come down on the coders who would query, well, why are you querying the physician over that? Because you're supposed to.
Right.
But that's what happens. So then what happens is now you have coders who don't even want to send queries or are reluctant to send queries. So therefore you have all this shoddy documentation floating around. That's the problem. You have people, and especially in outpatient, I'm telling you, these doctors have these CDI people right where they want them. And like I told you before, they told my boss, they didn't tell me, but supposedly in a meeting, I was aggressive. But the thing is, because you're not going to tell me something that's you're not going to pee in my face and tell me it's raining when I know better. When I first of all, I mean, first of all, you hired me to be the CDI person. So if I'm telling you that clinically that does not make sense, you have to listen, or you should listen. Because just because you don't agree doesn't mean that this still is unresolved. You still have to, and because their whole thing is like they were trying to, because like I told, like in outpatient, I don't know what it was, well, they're all trying to chase money, and they're trying to chase money because they insist on trying to suspect for diseases based on labs. You cannot solely rely on labs as a clinical indicator. You cannot. And when I tell you, I even saw an ad for a risk adjustment job, and they talking about lab suspecting. You cannot do that.
Right. Because again, we done stated at the end of the day, the provider needs to document the information. What?
And then because then I told them, because what they got actually, and I think I remember the meeting because one nurse, uh, she disconnected from the call because she and I had an exchange. So
Oh, Lord.
because we all know, I mean, the whole purpose now is this not true, Clarice? Now we're credentialed professionals. The whole purpose when you have someone, in for instance, an inpatient, the attending is the person responsible for that patient. If the attending orders a consult, that consulting provider does not trump the attending physician. Correct?
Correct.
The attending physician has to ultimately agree with that plan of care for that patient from that consultant.
Correct.
True?
Correct.
Okay.
Because
So,
unless they transfer the care to that
right,
provider, and then they take over
right.
the that point at that point, and then that person will then be managing that specific issue going forward in that encounter.
Okay, but does that really happen inpatient?
It's rare. Well,
Okay.
it depends.
So,
It depends if it's a specialist. It depends, but
right,
usually the attending still holds the reins and does
right,
whatever because most specialists would be like, I ain't got time to be coming over here every day. No
right. So, you know,
kid.
so they were trying to push on, not taking what like medications for labs, for instance. You don't know where the order came from. You don't know when the order was written.
Right.
And so she was like, "What?" So, well, a doctor would have to have written the order. I said, "Yeah, but not the doctor assigned to the patient. So it doesn't matter what they prescribe. The doctor that is assigned to them for our organization has to document that they agree with that. Period. That's how it works.
Yeah.
Even in long-term care, when you send people out to a specialist, when they come back, because I've done it a gazillion times, when they come back, whatever recommendations, whatever orders that specialist has, we have to call their provider and get a verbal order to institute that plan. So this has been around forever. I don't know why people act like it's new, but because people don't want to, they don't want to take their position seriously. They want to go along to get along. But in this game, go along to get along will cost your organization millions.
Millions. Billions. Yeah.
And just do it right from the beginning. You don't have to be bothered.
Do it right from the beginning. Lord. Yeah, so I was like, well, wait a minute. This whole buzz, I'm still trying to, I'm like trying to follow folks so I can figure out, well, what's happening? Well, where's all of this?
And
Well,
because when I saw the false claims, I'm like, wait a minute.
y'all look, y'all
That's why I
jumping into
tagged you.
compliance territory. Look, that's when I started looking like, well, wait a minute. Y'all don't.
That's why I tagged you because I'm like, what is going on
You
here?
know, I was about to pull up the whole false claims. Like, let's talk about what a false claim. Sorry, you know me. We gonna get a even playing field. We all gonna have some understanding of what it is that we talking about before we talk about it, right? Right.
Right.
Folks be jumping in on the tail end of folks' coattails and don't know the Kool-Aid that they jumping in. I'm like, oh. So the other part, kind of piggybacking on what you said earlier from Ahima and them reaching out to you about their CDI credential. So they in their article they talked about advancing the coding profession with communication skills, clinical skills, and credentials. Of course, the credential that they're referring to is the Certified Documentation Improvement Practitioner, or CDIP credential. And how that the person who earns this credential, and we'll definitely let Mr. Jesse weigh in, will be distinguished as knowledgeable and competent in clinical documentation and patient health records, and be positioned as leaders and role models in the HIM community. See, I just knew. Let me grab my tea because I was waiting for it to come. I knew it was coming. But the one thing that they stress, and I think this is very, 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 very important, particularly for coders, and and this article was written a few years back, but it's applicable today, especially as we look at how in certain cases we have to pivot our roles. You know, we've talked several times about AI and you know, computer programs that may do some of the low-lying fruit that coders do, and if you're looking to maybe pivot into kind of auditing or other functions, communication skills are really, really important. You got to be able to communicate. You can't, and I know because I saw it and I couldn't believe it. I saw it with my own eyes. I witnessed it with my own eyes, where you had a person who was really, really afraid to talk to a doctor, like afraid to even just have a like they were like a whole aura was just surrounding them as they walked through the halls, like, oh, look, I was like they wanted to turn their head, like didn't want to look them directly in the eye, like something was gonna happen. And I'm like, what is going on here? Like when I saw it, I said, are you okay? Are you okay, sweetie? And she was like, yeah, that's Dr. So-and-so. And I was like, well, you just say hi, like whatever, you know. And so I think if you have to humanize people, that you can't put them on the pedestal. And I always say they put their pants on or skirts on just one leg at a time, just like I do. What? Ooh, I don't understand. But you need to be able to talk to folks, either, and I talk about folks having keyboard courage as well. So even if you got the keyboard courage, that having that written and oral communication skill is essential for those in healthcare, period, because you have to be able to interact with all of the clinical staff, not just the physicians, but any other mid-level providers, your nurses, anybody from any specialty, and they may be a specialty different from yours. So having the conversation, you're wanting knowledge, you're wanting information, so you have to be able to ask the questions or talk to them. The one thing about our profession is, you know, we got to be knowledgeable of a whole bunch of things in a whole bunch of areas. So we got to know all kinds of stuff. And then we have to be able to be concise. Good morning. Good morning. I have all the folks checking in on YouTube. We have to be able to be concise in how we relate that information. I mean, we don't necessarily got to, that's probably one of the issues with query fatigue, because sometimes folks want to write a whole dissertation when really it's not. Ma'am and sir, you don't need all of that. Get to the point. Let them determine what it is that you need, but you don't need a whole 5-page document to get the information that you need. So be concise.
You know what I would just piggyback and say that what I think AHIMA should do, since they want to position themselves as an industry leader, I think that what they need to do, they need to come out with a document that talks about the role of a coder, because they have a very lengthy code of ethics
Yes, we do.
of what a coder is supposed to do, but they never talk about the role of a coder. And the role of a coder takes on many hats.
Very many.
And that is one thing that nursing is very, very good on. Because one of the very first courses you take in nursing is the role of the nurse. And they talk about the nurse as an educator, the nurse as an advocate, and the advocacy piece that's what gives nurses a little leg up, because I've mentioned this before. Like, the reason why nurses make very good people in CDI is because they're not afraid to go toe to toe with a doctor, because they've done it. I've done it clinically, when you're taking care of a patient, because at the end of the day, we're all legally responsible, and I'm not going to let your incompetence affect my ability to eat and stay out of prison.
Amen.
So and so it's not easy. That's why it's easy for me to be in these meetings and say, no, you can't do that, or no, that's not what this is intended to do. Just because you want to maximize profit, you maximize profit by documenting appropriately and giving people appropriate care. That's how you maximize profit.
Okay, I can't. There is an article. I don't know how old it is, and I'm looking at my phone and not my computer, so I can't get into it uh, yet. But there's an article, and you posted an article. I don't know how old it is either. I'm sorry. The evolving role of the coder, current to future state. Um, and it talks about the coder of today will not be the coder of the future, and I think it gives some information. I'll pull that. I'll pull that article.
When was it written?
I'm trying to see. I just did a.
Oh, okay.
Because it's in the body of knowledge, and so it's asking me. Wait a minute. Let me see if I can log in from my phone. Sometimes it be acting funny. Sometimes it'll let me, and sometimes it'll act funny.
Well, this is some more AHIMA tea. Apparently, AHIMA is revamping their CHPS um, credential. There's certified in healthcare privacy and security,
Mm,
because the new test launches in September. They also are coming out with an exam prep course that starts in late July and it ends in August, to prepare people for this September test date.
mm.
And I'm like, hmm. So I did a little research, and I watched a couple videos, and the one guy who I really did like his video, he was like, because of course they have an exam guide, and he was like, the exam guide wasn't really all that helpful, but he had worked in IT and he had worked in healthcare, so he was able to pass the test on the first try. He said that the questions mirrored the questions that were asked on the test in terms of format, but not in terms of content.
Really?
And I'm
Isn't
like,
it the
well,
same thing
that.
you've been saying forever?
Hmm.
I just
And
don't
so
know.
I'm saying to myself, okay, so if they are coming out, and then I went to the website, because to me, if you have a new test that's launching in like basically 2 months or 2.5 months, why haven't you updated the book? How come there's not a new exam prep book if you have very clearly that this? And then the thing is, this new test is going to have a beta period.
So why are they not preparing people now?
Listen, this is what gets me with a HEMA. The only way you're going to pass that test in September is if you take this course that they're going to offer in July, because it's a hybrid. It's not a hybrid, but it's an online course. But you even get one-on-one instructor time to ask questions, and you have all these groups. So I'm like, this sounds like, to me, like they're trying to do some kind of study. They're trying to do some kind of, like, you know science project to see how effective this training can be for this updated exam. That's what it sounds like to me.
And I mean, I can appreciate, getting some research on that. I get that part, but what if you can't do the course in July? What if you can't do, what then why wouldn't you make the materials available for those who may want to self-study or study in groups or what have you? Why?
It's gatekeeping and it's money because
At its finest.
because if you don't have 795, you're not going to pass that test in September when they revise it, and you're not even going to get your results in September because because they have a 10-week beta period.
Really?
Yes, this is all on their website right now.
Oh my goodness.
It's like they never cease. It's like, geez, like they are determined to put you on the host stroll. They are determined.
Just picking you out there. Oh my goodness.
Yes.
That is horrible. Okay, I'm feeling some kind of way. I keep getting every time I get in here. I'm gonna have to look that up. The evolving role of the coder, current and future state. That's the name of the article in the body of knowledge. It's for whatever it's giving me this little thing when I try to log it. It does it all the time. So I don't know if I have to be in a certain. I don't know if it's because I'm on a Mac, so I don't know if it's Safari that's doing it or if I have to go into Chrome and do it, which may be the case.
But I never use Safari. I have a Mac. I only use Chrome.
I prefer Firefox. That's my jam. But
I used to use Firefox, but I had to let it go because it just fell out of favor. Everything's supported by Chrome now. Everything's Chrome.
It is, but I all Microsoft stuff makes me nervous. That's why I feel like it's prone to viruses and attacks, and it just makes me nervous. So I'd be like, let me stay over here in my locked up area. But I'll do it. I can't. Well, we're on Chrome doing StreamYard, so I can't do it on Chrome. But I'll look it up and maybe we'll have it for discussion next week. How about that? And we can break down what they're saying.
So that's all I have. Like this new and I'm like, and what can you do with the CHPS? That's what I want to know. Because
so what the part that gets me is why can't people just stay in their lane? Let's start there. I feel like you have organizations who have been proven to be the quote unquote experts in certain areas. Let them do that. Why does and AAPC is notorious to me. Like you had your lit niche, you had your whatever. What is all this other stuff? And why? To me, and we talk about, even with HR people being confused about whatever. Hell, I would be confused. What is all this stuff? What does this mean? I don't know what this means. I don't know. So how can they accurately or appropriately convey the information to hiring managers or whomever about all this stuff when it's all muddled? Hell, you can't keep up. You can't keep up. Like tomorrow, there may be another group dropping in the world saying, "Okay, well, we are the expert in clinical documentation, and you should follow us." I mean, granted, folks gonna give them the side eye because they would be brand new. But if they had enough followers or enough people to vouch for them, then here you go. So now you done diluted the waters even more. I don't understand that. I just stay in your lane. That too. It's about the money. I've always said, follow the money. Anytime you want answers to questions, follow the money. And you're right.
They're like, look, these people are getting all this money because they're looking at, because the one thing about AHIM, at least they do publish how many people a year pass their credential exams, and they tell you how many people are credentialed, how many people hold a certain credential.
Mhm.
AAPC doesn't do that. So if you just do a quick little calculation, you can figure out how much money they're making off of exams.
I'm about to start writing exams. Look.
And they're like, and the AAPC is like, we're gonna try to get some of this. But I think that, like that whole, I don't know, like the whole CIC thing. I'm like That's now I have seen a few places that are starting to accept that, either that or the CCS. So it's gaining some traction. So we'll see.
I'm okay.
Because but here's my thing. If you're trying to compete with a HEMA, then your exam should have it should have the same components, because the whole the whole kick to work an inpatient is when you work inpatient, there also most hospitals have outpatient offshoots. So you have to know how to do outpatient coding as well. And if you're not tested, or if you don't already have a CPC, then you don't know the CPT code set.
Correct.
Because the CIC, you're only tested on ICD-10, CM, and PCS, not CPT, like with the CCS.
Hmm.
So
So you coming in at a disadvantage all the way. And
right,
then, I mean, to me, what's the value of that credential? You don't have the information. I mean, you can learn it definitely, but what's the value of that credential? I don't know.
right.
Mm, crazy.
And to me, like I don't know. I just know, like, excuse me, like from me tutoring at the college, I've just seen that HIM education needs to be revamped, period.
Mm.
And they don't, because the bottom line is people can say what they want to say. And I even tell my students, everything in healthcare comes down to money. Everything. Every code that you assign is attached to a dollar amount. Every. And if you don't understand reimbursement methodology, you'll never understand coding, because everything is really comes down to that. And you want to be able to, and your documentation allows you to keep said amount of dollars, because if your documentation is not right, they're going to come and snatch it. And you have people, you have these schools, these people don't truly understand what an MSDRG is. They don't truly understand what an APRDRG is and the components. They don't know how to manually calculate an MSDRG. And the reason is because they have instructors who don't know how to do it. That's the kick.
Or they feel like that's not my job. That's somebody else's job. Let
But
them
if you're
handle
but if
it.
you're teaching but if you're teaching ICD-10, CM, and PCS, that is your job.
No, from an education
Right.
perspective, oh,
Right.
all definitely, definitely. However, from in the trenches, in the actual, they're like that's somebody else's job. We don't have to do that.
Well,
But you are 100% correct from an education perspective. You got to give the background. You got to you set the foundation so folks understand. Well, what are we talking about? Why are we doing what we're doing? Where is all of this coming from? You got to give the history. You have to give the information. Now, whether they use it, they may not ever use it, but they know they've heard it.
and that's why I do give a HEMA credit, because you can, just a regular person can go and buy access to their 3M encoder.
Oh, really?
It's $75 a year. You go to VLab, and you just select medical coder, and it's $75, and you have access to the entire 3M suite.
It's just
You
an
can,
individual license or whatever.
yes.
Okay.
Mhm.
Well, that's good to know. That's
And
some tea
yeah,
spill. I love it.
and you can practice doing MSDRGs, APRDRGs. You can practice using the because you have access to the 3M coding software.
Now, do they have
You know,
like test patients or test cases or test stuff in there? I mean, how would you?
you you can get access to that, but that's I don't think that's included in the
So you would just have to have
the
your own kind
75.
of scenarios working
Right,
to
because
figure out.
actually, because here's the kick though. Schools use it. How I found out about it is because the school that I tutored, they had I had my own account. Students had their account because I had a HIM administrator account because I was a tutor. So you get access to like all kind of cases. But the thing is, they would assign the cases, but they wouldn't explain to the students how to do them because they didn't know how to do them because he wasn't a coder. So there was no, like, they didn't even know how, he couldn't even tell them how to use the encoder. So,
And they pay how much money for this? No kidding.
oh, it's expensive because it's a private college.
Oh Jesus! And they don't know any better. You don't know
Mm-mm.
any better.
Until it's too late.
Until it's too late. So you sitting there looking at the stuff like I've never even heard of this. What is this?
Because, oh, let me tell you. So I had one of my former students. So she called and she was like, I saw these CDI jobs. I think I want to apply for one. I said, so I said, so when did you learn about APR DRGs? Because now I know I taught them some things in the class. I said, but do you know? I said, but if somebody asked you what are the two components of the APR DRG, what is it? What are they? Crickets. And I told her, I said, I said that's all well and good, but you have to be able to, when you get an interview, you have to let somebody know you know what you're talking about. And if you walk in there talking about, well, I saw this position, I think I'll be good for it. I'll be a good fit because I know something about coding. Okay, you might know something about coding, but do you know the protocol for sepsis? Do you know the clinical indicators and you know how to interpret arterial blood gases for respiratory for acute respiratory failure? Do you know whether it's metabolic or respiratory? Do you know whether it's alkalosis or acidosis? Like these are things you need to know.
That was
Like
one of
what's
the
the
things in the I'm sorry, I didn't cut you off.
mm-hmm.
That was one
Go
of the
ahead.
things in that article where they talked about like a coder would know. They gave an example. Like these are signs and symptoms of an actual condition. Like a coder knows, for inpatient, you don't code all these signs and symptoms. What is all of this? You code the condition. What but somebody who I picked up a ICD-10 book and I know where to find each one of these things. They're in their mind. I need to find each one of these things. They don't know the ins and outs and the purpose and the method to the madness to be able to accurately code those cases. So to your point, yeah, don't jump over here if you ain't ready.
Exactly, because you need to know what the criteria is for acute kidney injury. Because, for instance, if somebody's in a hospital with sepsis and you miss, because there's a formula. If you miss that they've had a decrease in their creatinine by a certain amount, I think it was in 24 hours.
Mm-hmm.
That is a criteria for acute kidney injury. Why that is important is because now if you see that, you can talk to the provider and ask the provider, is this related to sepsis? Because then you can code severe sepsis
Mm-hmm.
and you can get a higher DRG. But if you don't know that, then you leaving money on the table.
On the table. On the table. I
So
was
these people, it's more than just getting. It's just you have to know how to do a job, and these people are not teaching people how to do the job. That's like I tell my students, like, I teach you how to code. That's why I have very very few multiple choice questions. They have cases, they have questions, scenarios from day one because that's what they hand you a chart, and your charts don't have multiple choice options.
correct. So, like to your point, just like you in my sessions, I'm giving you those scenarios. When we get closer to trying to get you prepared to take a multiple choice exam, that's when we play around there. But when you're learning how to code, you need information. They're not going to give you options when it's time to sit there and code those charts. You're not going to get any options. You have to know. You have to know. Yeah. Joy, oh joy.
Yeah. Well, look, we have covered some territory today as usual.
I love it. I was like, when you said that to me, I was like, wait, what is this?
I mean, you wasn't they were disturbed. It was an uproar.
Disturbed. And hopefully, hopefully I'm gonna figure out how to we gonna put this over here on LinkedIn. Like y'all weigh in. I'll send you link. We gonna figure it out. Like maybe this will help you. Maybe how about that? Because y'all throwing around false claims, don't do that.
Exactly.
Don't do that. Don't be throwing around that treble damage and stuff. Don't do that. Don't do that.
Look, as they say, team too much. That's
Way
team
too
too
much.
much, right?
Way too much. Stop. There's a comedian that a group I follow, and he always hitting his camera like, stop,
Right.
stop that. Well, this was good. And we will follow up with that. I need to figure out how to, because I think we could do like LinkedIn Live. That's my next one to learn. How do I connect with LinkedIn Live? And maybe we can also broadcast on LinkedIn on Saturday mornings as well. Look at us and platforms and stations. Don't play. Don't play. Oh, well, yeah, this was good. And you dropped a lot of tea, and I got some comic relief as well, because I know how you are. I wish I could have saw the whole document that you submitted to AHEMA, because I know it's funny. And I have already in my mind decided, even though we're talking in my role as advocacy for OHEMA this year, is to reach out to some of these other organizations and associations to find out, well, what are we doing about our organization? Why are we not at the forefront of making sure we're advocating for the roles that our people can do? Why are we not doing that? Why are we silent? I don't understand. Yeah, I see y'all internationally reaching out to tell folks, oh, you got this and you can do this and you can do this. You got folks right here on these waters that need that same encouragement. That need that same information. So why are we not doing that? I don't. So inquiring minds want to know, and inquiring minds going to ask some questions. So stay tuned, y'all. Stay tuned.
And I want to know, what is the big deal with this CPHS?
Yes.
I gotta, because
I'm gonna
when I
task
was
you.
reading it,
You're gonna be the man on the street. Let's go.
because I'm like, what? Like, then I saw that like they have an exam prep, and then I see when it starts and when it's timed, and I see that they have an update for the CPHS exam, and it says September, and then it's at a beta period. I'm like, so that sounds new to me. That's giving newness tea.
newness, but not providing the information. So who
Hmm.
gatekeeping at its finest? We need to kick some gates down. I feel a gate kicking coming. Like,
Because even on the website, now when you go to the website, they still have the four domains, but something has changed. Anytime you have a beta period, they only have beta periods when they have new exams. Because my CDIP wasn't no beta period.
well, to that point, let me think about that. So there is new. The ONC has provided some new information on privacy and privacy regulation. So maybe they are tapping into that, possibly. I mean, but you would think you would update that on a regular basis in your testing material. Anyway, I mean, you would stay current and update appropriately, right?
Right, because we all know, like for the CCS or for the CCSP, but this is interesting. Before they always had beta periods when
Right.
they started in May 1st. Now they don't even have beta periods anymore. So why is there a beta period for this test?
Yeah, I'm gonna need you to put on your sleuthing hat and get to digging. Oh,
Look, I sure will. Look, I'll go right. Look, I've been going to a HEMA on LinkedIn, found all them people and send them an email. Like, what's going on? Why? why do you have a beta period for this credential, but all the other ones you did away with? Like, there's a reason.
There's a reason. Something's happening. And maybe it's all about following that money again. Maybe following that money. Interesting. Interesting. All righty. Why does
All
anybody come
right.
up to the stage? Or anybody have any questions or concerns? So we appreciate everybody being here and joining
Yes.
us today. This was a great Saturday. A great Saturday. I believe the tea was spilled. Was the tea spilled today?
I think so.
All
So
right.
nobody wants to come up.
Don't be scared. Come
Exactly.
on. We don't bite.
Exactly.
And we'll probably do in the next week or so. Well, I'll let you know for certain. Next week or the week before, we'll have some Q&As. And so if you have specific things that you want us to kind of take a look at, feel free to um, get in our inboxes. Is that what they do over there? Inboxes, or it's some
Oh, a back channel.
back channel. There you go. See, I knew somebody was keeping up with that terminology. Back channel us, or get in the DMs on Instagram or email, or however you need to contact us, and then we can definitely assist you and answer some of the questions. I think that would be a fun session to have, just a whole big Q&A. Even though I probably got stacks of Q&A questions from folks over the years, where we could just have wonderful dialogue. So again, if this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the channel. You can also check out the Coding Nurse channel on YouTube. Yes, dropping gems over there. Last but not least, to my Clubhouse folks, remember to click on the green house to join the fun in our club, and you will get notified of our live broadcast. Yes, okay. Vicky put a comment in. Let me see. She said she will definitely watch the video again from the beginning. Yes, and there were some gems dropped, ma'am. There were some gems dropped. So thank you for being a
Definitely.
part. So again, this has been a great session today. Thank you all for joining. We're here every Saturday at 9 a.m. Eastern Standard Time. So feel free to go
Well,
ahead.
I just got a message from Doug in the audience. He said, "Just got here. I'll try to join next week."
Well,
So
go
because
on.
Doug is in our room fairly often,
Yes, welcome to.
and he's an RN case manager.
Oh yeah, we gonna have to bring you on the stage. We need to
Definitely.
talk. We need to talk. We'll set up some time and see when you are available, so we can pick your brain from case management perspective. And Lord, I'm gonna have to battle two nurses on one stage. Lord, give me some strength.
Oh, let me tell you, it'll be easy. It'll be easy with two men. You won't have a problem.
You're like, oh, let me get my guards together. Look, let me find me some other folks over here. Maybe we'll have a little round table discussion to discuss that. So yeah, let's put that together. That'll be fun.
Yeah, because I'm sure Doug has a lot to share because they have a whole lot of guidelines too that they have to go by.
Definitely.
Those like by utilization review, like it was the Millimans and then Interqual.
Oh, see, you
So
just hit me because that, yeah. Because we got some new information about that. There, I've seen from the compliance perspective, um, where especially with the 2 midnight rule, and they've been talking about that for years. I remember when the 2 midnight rule, yeah, we're gonna bring that up. When the 2 midnight rule came out, and folks have just solely been using these interqual and Milliman criteria as the purpose for determining whether or not the person should be inpatient. And they've told them a gazillion times, no, it's real clear in the criteria of what it is that you're supposed to do to determine whether or not this is an inpatient admission. It's real. And basically, is this person going to be here over 2 midnights? Yes or no? But people, well, that's a whole other conversation. We could be here for another hour.
It
We won't do
is.
that. So
Because then it gets into, because it just becomes such a snowball effect, because then you have people, if they're discharged too soon and then they're readmitted within 30 days, then that's a problem.
correct.
So it's,
But there's a way to do it, and you're possibly leaving money on the table if you don't follow what CMS guidance was. It's real simple. Yes, Milliman and Interqual gives you all of these. See, it's similar to the whole little CDI protocol thing that y'all got going on, but they give you all of this convoluted. Follow this, follow that, do that, and that's fine, well and good. And if you need that to support, it's there for a reason. But it's guidance. They're telling you this is what you need to do for this to be an inpatient admission, period. Understand. And do you think right now, today, this person that's sitting before you, will they be here for at least 2 days or 2 midnights? Yes or no?
now this is what I want to know, because I do the protocols apply to the uninsured too?
It shouldn't matter. Your insurance, that part technically shouldn't matter. But for
Oh my God.
yeah. Because first of all, and now we gonna be here. So first of all, you provider should not be like, well, wait a minute, what's the insurance before I determine so and so. No, your job is to take care of that patient. Period.
I'm not saying it's the doctor, but when they come around, when that admissions rep comes around to your little cubicle in the ER
No,
and takes
you
your
got providers. You got providers who like, well, wait a minute, or somebody in their ear. Hey, this their insurance. So you have this
right. It's that admissions person that rolls around with that little computer and takes all your information, and then they're like, you don't have any insurance. Then they roll back out, and then all of a sudden, that's when things start to change, because then they're like, we got it. It does.
Lord Jesus.
Because then they're just trying to stabilize you. They're not trying to treat you.
They're not trying to treat you. They're gonna stabilize you.
Right.
And then you still go. But then you got the other people who, well, let's see whether or not we can get them insurance. Let's see if they're Medicaid eligible. Let's see, whatever. And then it's a whole hamster wheel going on. And why? If you just follow this, yeah. I see some topics in our future.
Yes.
You're gonna make me put on my compliance hat all day.
Good, because look, who else is talking about this?
You're right.
And this is the real deal. This is what you have to deal with once you leave school. It gets very real very quickly.
And then you get those whole denials like, well, why is this whole case denied? Well, let's start from the beginning, as my friend used to say, the beginning. And this is why. Okay.
Mm-hmm.
All right. You done got me all riled up for the end of the show. All righty. So again, this has been a great session. I look forward to seeing you all again next week, 9 a.m. Eastern Standard Time, YouTube, Facebook, Clubhouse, and maybe LinkedIn if I figure out how to do it. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Have a great weekend and talk to you soon.
All right. Bye-bye.
Bye-bye.